Dear chairs, dear audience, allow me to present my PhD thesis, New Insights in the Management of Partially or Completely Edentulous Patients. I am Yasir al-Muhammad, a dentist from Iraq, second year PhD student. My supervisor is Gabor Varga. My SMS is Esther Salai. My vision is to provide the patient with a durable, aesthetic, and comfortable prosthesis. My mission is to investigate the recent evidences regarding implant abutments in fixed and removable prosthodontics. I have two ongoing projects. The first one is comparing long-term success of zirconia polyether ether ketone and titanium implant abutments, started in September 2023. The second one is about soft liners, which is started in November of the same year. The first one is a systematic review and meta-analysis. Well, in a study in 2020, there is more than 240 million USA citizens that's partially or completely edentulous. And in another study, there is more than 500,000 patients in the USA undergoing implantation annually. So there is a compound annual growth rate of implant industry and market of more than 5.7%. Implants have a lot of components. One of them is the implant abutments, which could be made of a variety of materials like titanium, zirconia, and gold, polyether ether ketone. Each material has advantage and disadvantage. Like titanium is the gold standard, but it is gray. Zirconia is smoother surface, more aesthetic, but it is fragile. Polyether ketone is a polymer. It was used as temporary. Now it has more aesthetic, smoother surface than titanium, so it could be used as permanent abutments. So that's why our clinical question is, what is the performance of polyether ether ketone, zirconia, and titanium implant abutments in clinical practice? According to that, our PICO framework is the P is the patient with implants. I intervention is titanium abutments. Control is the titanium abutments. The intervention is zirconia or PEK. The outcomes, we have multiple outcomes. We divide it into efficacy, safety, and cost, as I will show later. Our hypothesis is that zirconia and PEK are non-inferior to titanium regarding durability with better aesthetics. Our clinical or research implication is the improvement of durability, aesthetics, and functioning of implant-supported prosthesis. We started our search on November 2023. This is our search key. We started with more than 11,000 articles. We ended up with 33. I will show some of my outcomes. Actually, we divided it into two parts. Direct comparison between zirconia and titanium, which we included RCTs and non-RCTs. This was a lot of studies to compare the two types, and we have the network analysis of zirconia, PEK, and titanium, as I will show next, where we included only RCTs. So regarding this outcome, the survival rate, we have a direct comparison between zirconia and titanium, and it showed that non-significant difference between zirconia and titanium, regardless of the follow-up period, which we included in one group rather than subgrouping, up to 13 years of follow-up. Second one is the soft tissue discoloration, and in this outcome, they measure the difference in color of the soft tissues compared to the adjacent natural tooth. So when the value is less, this means better. We should inform the statistician about that, and we have this, the network analysis of the three types of abutments. As you see in the figure A, this is the rankogram, which shows the P-score. The P-score shows the B-score, the P-value, and it is closer to 1 means better treatment option. So as we see here, PEK is the best and titanium is the worst. But if we see the C, it is the leak plot, which shows the confidence interval. And in this, it showed, because to the limited number of studies, we have wide confidence interval. So we cannot say this treatment is best, but we can say that there is no significant difference between the three types with comparable results of PEK with both titanium and zirconia. Third outcome is the papillary index. We included as the aesthetic group because it measures the ability to close the triangle. Of course, better values means best, and there was non-significant difference between zirconia and titanium, but there was a general tendency of better results with zirconia. Fourth or final outcome is the bone loss. Of course, less bone loss is the best, and according to the rankogram, network plot, league plot, and the forest plot, we see that there was non-significant difference between the three types of treatment with very good comparable results of PEK. So our strength is that we have multiple clinical outcomes. We have multiple follow-up periods ranging from 1 month to 13 years. We did a network analysis of RCTs. On the other hand, we included RCTs and non-RCTs, only few studies concerned with PEK, and there were heterogeneity in the measurement of some outcomes like plaque index and the bleeding on probing due to multiple indices. Our conclusion is that both titanium and zirconia are effective and safe. Zirconia associated with better aesthetics, and PEK abutment showed an excellent comparable results with both titanium and zirconia. Implication for a practice is that zirconia and PEK can be used as alternative to titanium with better aesthetics. The implication for research that more studies concerning PEK and the cost effectiveness should be included, and the difference between customized and stock abutments. This is our progress in the first project. Actually, we'd like to submit in Periodontology 2000, which is not only a D1 journal, but the #1 journal, and it has should be with a special invitation, and thank God and to the efforts of my supervisor, maybe we will get that invitation, and we submit maybe, I hope, this week. We are now in the level of language editing. Second one is the investigating the efficacy and safety of added soft liners on removable dentures. In a study, there are more than 36 million Americans having no teeth completely. 90% of them having complete dentures, 15% of those renewing their dentures annually due to the progress of residual ridge resorption, which is the continuous tissue changes underlying the removable dentures. And these should require frequent relining. And one of the relining material is the soft liners, which added an advantage of cushioning effect and shock absorption. So our clinical question is that does the addition of soft liners improve the mastication and chewing ability of patients with removable dentures? According to that, our PICO framework is P, patient with removable dentures. The control is no addition of soft liners. The intervention is addition of soft liners, and the outcomes are patient satisfaction based on visual analog scale, chewing ability, also visual analog scale, and masticatory performance, which is measured in a test tubes of the amount of material to convert it into a fluid before and after in a special equation. Our hypothesis is that adding soft liners improves the chewing ability and mastication of patients with removable prostheses. Our clinical or research implication is that improvement in comfort, durability, and functioning of removable prostheses. This is our preliminary research key. We started a search. We found some key articles. There was no previous meta-analysis, only systematic reviews in this field. And we did some preliminary data extraction. We checked the feasibility with the statisticians. It is a feasible topic. And I'd like to be able to submit the first project in this month and the second one in June 2025. And allow me to finish with a quotation by Stephen Covey: "Success is not an accident, but it's actually a choice." And thank you for your attention.
Yes, we know there are, of course, very different types. Let's focus on the titanium implants. Was there any specific type of titanium implants you were considering, or was it just general anything, any shape, size, form, surface treatment, or something particular?
You mean implant or abutment?
Implant. Also you were talking about the abutments, right?
Abutment, no subgrouping, only titanium in general. We didn't consider that the shape, the form, the surface treatment, because there was very limited studies, like only for direct comparison.
All right, thank you very much. In regards of the patient you included, so the patient who underwent the implantation, what was this population group? Was it anything particular? Did you focus on systematically healthy patient, or was everyone included? How was this?
Of course, a systematically healthy patient. Only like acceptable maybe amount of cigarette smoking, but other than that, no other medical problem.
And in regards of oral hygiene, was there anything given for this as well? Because this could have a huge impact on implant survival, of course.
We didn't focus on that, but it was like only within the limited, like acceptable clinical oral hygiene. No subgrouping, no periodontally involved teeth, only the good health with good oral hygiene patients.
Because they would have been probably excluded in the articles you included already, right?
Of course, and the RCTs or non-RCTs, yes.
Did they measure fracture rate or?
It was actually, the fracture was measured not in the RC, it was only in vitro studies where they measured it either mechanically or in the finite element analysis. But For the clinical studies, they didn't mention this.
They never had a fracture.
No.
Yes, usually they never.
Only maybe in the technical complications, they said like we have an outcome called the technical complications. They measured that discementation or chipping or something, and we had it in the comparison.
The screw loosening, maybe.
There's about, in general, the crown, the chipping of the crown. So we mentioned it in the comparison.
And what was the result of this?
And the results, it showed that regarding the RCTs, there is no difference. But regarding the direct comparison, there was better results with zirconia. So there is more technical complication with titanium, actually. It was surprising, but this is what we found. It was because there is a lot of confounding factor in this outcome, like the type of cement, the parafunctional habits, the anterior or posterior. So we discuss it thoroughly in the discussion part, the technical complications. We give it because it's really not that direct. It has a lot of confounding factors.
And what is the result of in vitro studies if you come up with some studies in terms of the fracture, which I asked?
Actually, we didn't.
So like mostly I'm interested in the peak. That is it compatible to comparable?
I didn't check it because we exclude the in vitro studies. Maybe in the another topic.
Regarding figure 4, your bone loss, the bone loss was measured in which time relation? Just after implantation or in relation to after tooth extraction and then implantation and further on?
After the follow-up period, after the implantation and then after the follow-up period. At the follow-up period, like 5 years, 1 year, 13 years.
In relation to the baseline was the time point of implantation, not the time of extraction. Okay.
Yeah.
Was there anything mentioned about different loading protocols which might have an influence on the bone resorption or bone loss?
No, actually, no. It was only like the delayed loading protocol.
It was always a delayed protocol there. All right.